and thank you for listening to the Wheel Talk podcast. My name is Abby Mickey. Normally, we would be coming into your feeds with Gracie Elvin, Lauren Rowney, Georgie Howe, and myself to talk about women's professional road cycling, and we've got plenty of very good bike racing talk coming in the next couple weeks. Later this week, Georgie and I will preview the women's Giro d'Italia, which starts on Sunday, July 6th with a time trial in Bergamo and kicks off right away with a hilltop finish on stage 2. But because we don't know the start list yet, we're going to hold off on a full Giro preview until later this week. That meant that today we had an open spot, and what better opportunity than to highlight a piece written recently by Matt de Neef this podcast day. Matt did a deep dive on iliac artery endofibrosis, and he's going to read that piece for you here today for this episode. I'm really excited to not only get Matt back on the podcast, but also to highlight this really important piece that he wrote and topic in cycling. Iliac artery endofibrosis is becoming more and more prevalent in the peloton, and more riders are undergoing surgery to correct it. So I'm really excited that Matt was able to dive into it a little bit, put it in front of more people, talk with some riders who have experienced it, and also read this piece for you today. So, audiobook style, here's Matt de Neef.
The 2024 season was a big one for Sarah Jagante. For years, her vast potential had been thwarted by illness and injury. But in 2024, the Australian climber finally started to show the cycling world what she was truly capable of. A win at the Tour Down Under was an emphatic start. Then came 5th on a stage at the Vuelta Femenina and 7th overall at the biggest race of the year, the Tour de France Femmes avec Zwift, including 8th on the race-defining Alpe d'Huez stage. Throw in some promising breakaways throughout the year, not least being off the front for more than 120 kilometres at Liège-Bastogne-Liège, and the young Aussie's star was definitely on the rise. But Jagante was also struggling. She'd long had a dull ache in her right leg at rest, but in mid-2024 that ache turned into numbness and considerable pain during hard efforts on the bike, including during her impressive Tour de France Femmes. By September, the pain had become unmanageable and, in Gigante's words, quote, pushing through was no longer an option. Even recovery rides became very painful, and the aching at rest off the bike increased as well, end quote. By November, Jagante had been diagnosed with external iliac artery endofibrosis. A week later, she was in surgery to treat the condition, forcing her off the bike for months. Gigante's story is an increasingly common one in professional cycling these days. It seems like every few months we hear about another pro rider forced from the bike due to an iliac artery issue. Fabio Jakobsen is the most recently affected, but in the past decade or so, many of the sport's big names have been sidelined as a result of this debilitating condition. Marianne Vos, Pauline Ferrand-Prévot, Bob Jungels, Fabio Aru, Annemiek van Vleuten, and Amanda Spratt, to name just a few. From the outside, it seems like the condition is becoming more prevalent. But is it really? And what do we know about external iliac artery endofibrosis, why it happens in cyclists, and why it's so rare in the regular population? Let's start with the basics. The iliac arteries are the large blood vessels in the abdomen responsible for moving blood from the heart down into the legs. In the abdomen, the aorta, the largest artery in the human body, splits into the common iliac artery on each side. That then splits into the internal iliac artery to bring blood to the pelvic and gluteal muscles, and the external iliac artery, which descends into each leg to supply the quadriceps and other working muscles. It's the external iliac artery that's most prone to damage in professional cyclists. If the external iliac artery is narrowed or compressed, blood flow is limited and the muscles of the legs don't receive the volume of oxygen they need during intense efforts. This can lead to a range of symptoms: cramp-like pain, numbness, swelling, a heavy feeling, or an inability to produce power. Any or all of the quads, calves, glutes, hamstrings, or feet can be affected. These sensations normally subside a few minutes after an intense effort ends. Here's how Sarah Jagante described the pain she experienced prior to her endofibrosis diagnosis. Quote, "My whole leg, especially my quad, felt like it was being set on fire, even when riding quite slowly." End quote. We sometimes hear of this condition referred to as flow limitations in the iliac artery, or FLIA, as in the case of Picnic Postinel's announcement of Fabio Jakobsen's layoff. This is an umbrella term that highlights that the condition can occur in other vessels besides just the external iliac artery, like the common iliac artery or the deep femoral artery, plus the fact that the narrowing can be due to arterial kinking rather than, or in addition to, endofibrosis. But most commonly, the condition occurs in the external iliac artery, more than 90% of the time, and we normally hear it referred to as external iliac artery endofibrosis. So what is this condition exactly? In the words of Dr. Roger Bell, an Australian vascular surgeon who estimates he's operated on 50 people with external iliac artery endofibrosis, quote, "Endofibrosis is where you get a build-up of some thickening of the wall of the artery," end quote. Importantly, this process is not the same as in other vascular diseases like atherosclerosis, where an artery is obstructed by plaque. Instead, with endofibrosis, the thickening happens within the artery wall itself via an accumulation of loose connective tissue that's fibrous in nature. That thickening, plus any kinking that happens to the artery, then reduces the blood flow in the leg, causing pain and discomfort while the athlete is exercising. To explain why endofibrosis happens, we need to look at the biomechanics of cycling. While the medical literature isn't yet settled on the exact cause of the condition, there is a prevailing theory. It seems like the repeated stretching, compression, and deformation of the external iliac artery as a result of an aggressive hunched-over bike position, plus the massive volumes of blood passing through an elite athlete's arteries during intense efforts, causes damage to the arterial wall. But that's not the full story. Jem Arnold is a physiotherapist, escape member, and PhD candidate in exercise physiology at the University of British Columbia, and he's doing research on this very topic. He tells Escape, quote, "There seems to be a positional component, but we don't have any rigorous causal experiments that show, if you change your on-the-bike position, it's increasing risk. Also, all the athletes in the professional peloton are in an aggressive position, but not all of the athletes develop flair. So bike position is a factor, but it's not the only factor." End quote. The overdeveloped hip flexors of pro cyclists might play a role too. The external iliac artery and the psoas major muscle are connected by fascia, and with repeated flexion of the hip during cycling, the enlarged psoas muscle can pull on the external iliac artery, further contributing to arterial damage. Other possible risk factors seem to include previous injuries to the hip area, plus individual anatomical variations. That is, if an individual's arteries are more prone to kinking or twisting, that might increase their likelihood of endofibrosis. And there's another possible cause, one that hasn't yet been spoken about much. Dr. William Campbell is a vascular surgeon at Melbourne's Epworth Centre, who's operated on several dozen cyclists with external iliac artery endofibrosis, including Sarah Jagante. He tells Escape, quote, "I think the most current theory that I agree with is that there's a failure of the endothelium. So the cells that line the artery are just not producing the substances that cause blood vessels to dilate or increase in size. And so they have an opposite effect and cause vasospasm, so decreasing in size. Sometimes you see a bit of elongation of the artery because of the position they're in. And that was often a theory that this was an elongation and kinking. But I'm not so sure about that. That may play a part, but I think the thing that I see mainly is the dynamic change in the blood vessel at peak exercise, where, instead of dilating, it goes into spasm, and that cuts off the blood supply to the leg." End quote. It's worth noting that external iliac artery endofibrosis doesn't really happen in the general population. It's been reported in athletes from various sports, runners, speed skaters, skiers, rugby players, and more. But ever since the first cases were documented in the medical literature in 1986, cyclists have made up the bulk of those with the condition. That raises a couple of questions. Why have we only been hearing about this condition in the last 40 years? Is it only since the mid-1980s that cyclists have been developing endofibrosis? While it's impossible to say with any real certainty, it seems most likely that some riders would have experienced flow issues with their iliac arteries prior to the first documented cases. They just wouldn't have had a definitive explanation for the symptoms we now associate with external iliac artery endofibrosis. And that's because it's only in recent decades that doctors have been able to identify the condition and started to look for it. When you consider the vascular nature of endofibrosis, it's no huge surprise that the condition wasn't properly diagnosed until relatively recently. Dr. Bell says, "Unless you've come across patients with this condition before, the last thing you will consider in an elite athlete is a vascular problem." End quote. Vascular problems are normally associated with the elderly, rather than young elite athletes. As a result, even testing athletes for endofibrosis has proven challenging over the years. As Jem Arnold says, quote, "I've heard first-hand stories of athletes getting inappropriately tested for this. Cyclists having to run on a treadmill or even doing a walking test to try to reproduce their symptoms. It just doesn't make sense, right? The hospital vascular clinic is not set up to test athletes because they're expecting a much older and less functional, less capable patient." End quote. But things are slowly changing. As more riders are diagnosed with external iliac artery endofibrosis, and as awareness about the condition continues to grow, medical professionals and the riders themselves know to consider endofibrosis as a possible explanation for the relevant symptoms. And yet, even in the last decade, many cyclists have faced a long and frustrating road to a diagnosis. Not least because the symptoms of external iliac artery endofibrosis aren't dissimilar to the sensations that normally result from high-intensity efforts to begin with. Australian professional Sarah Roy's journey to diagnosis is representative of many riders' journey, in that it took several years to confirm that she had an iliac artery issue. Speaking to the media back in 2020, Roy said, quote, "The symptoms are so vague and that's what makes it really hard. Me coming back from training and saying that I'm dead, my legs hurt so much and I feel really lactic, that's not going to alarm anybody. I think it's pretty common for people with this condition to be misdiagnosed for years until they get to the final answer. For me, it got to the stage where my legs were so bad that I had to push and piss people off, get second opinions and trust my instinct." End quote. Sarah Jagante, too, now realises she likely had an iliac artery issue for several years before her diagnosis. She tells Escape, quote, "In hindsight, I probably had symptoms from at least 2022, maybe 2021. I actually organised an appointment to get this condition ruled out in 2022 because I thought I had very similar symptoms all the way back then, but life ended up getting in the way. Now, of course, I wish I'd followed through. I could have found the problem much earlier." End quote. Diagnosis of external iliac artery endofibrosis normally goes something like this. If other possible causes of leg pain are ruled out, injuries, imbalances, or other issues, and an arterial flow issue is considered a possible explanation, the athlete will try to reproduce their symptoms in a clinical setting. They'll set up on an indoor bike in the position they'd normally ride in, then ride in a way that provokes leg pain. At that point, blood pressure cuffs will be placed on one arm and both ankles to measure the so-called ankle brachial blood pressure index, the ratio of the blood pressures measured in the legs compared to the arm. In the case of endofibrosis, a drop in pressure in the ankle of the affected leg will be seen after a maximal effort. A duplex ultrasound of the affected leg after pain-inducing exercise can help to confirm the condition, with a higher blood velocity showing where kinking or narrowing of the artery is occurring. There's another, newer way to help detect external iliac artery endofibrosis too, and that's via a technique called near-infrared spectroscopy. Jem Arnold has been using this technique in his physiotherapy practice in Vancouver, Canada, to help screen for endofibrosis. He was the co-author of a 2022 research paper confirming that the technology is effective at detecting flow limitations. He tells Escape, quote, "It's kind of like your sport watch, which uses an optical sensor to measure heart rate. It's shining a light into the muscle, and the light is bouncing through the muscle and being absorbed by molecules that carry oxygen. And so the signal that's received back gives us some indication of how much oxygen is being carried in the tissue and how much is deoxygenated, or not carrying oxygen. And this gives us the rough sense of, metabolically, the balance of how much oxygen is being used by that tissue, very roughly speaking. Teams could potentially be testing this in their own environment, rather than referring the athlete to a vascular specialist. So at least there can be a first test to say yes or no, does this look like FLIA or not? And then the referral can be done from there." End quote. With the number and frequency of riders being diagnosed with endofibrosis, it's easy to assume that the condition is becoming more prevalent. But is it really? Jem Arnold doesn't think so, and his view is backed up in the literature. He says, quote, "I think it's mostly an issue of increasing awareness, which is a good thing, right? We're kind of understanding that, yeah, this is a potential condition that happens in cyclists, and so we're on the lookout for it more. Just like we're becoming more aware of the risks of concussions and energy imbalance and other invisible injuries. And by we, I mean clinicians, but particularly clinicians working with the teams and even athletes themselves are talking amongst each other a lot more, sharing information and sharing experiences. There's kind of a word of mouth thing, as I understand it, happening in the peloton. And so I think the diagnosis rates are predominantly related to just that increase in awareness. Maybe particularly even more so on the female side." End quote. Anecdotally, it seems like more professional female than male cyclists have been diagnosed with external iliac artery endofibrosis. The medical literature, meanwhile, speaks of far more cases among males. That's likely due to more male cyclists being professional and more research on men in general in the years since endofibrosis was first discovered. There are also anatomical differences between males and females that could affect the likelihood of developing endofibrosis. The wider female pelvis, for example, allows the external iliac artery to be longer before it kinks, which then requires a longer stenosis, a narrowed section of artery, before symptoms may occur. The narrower male pelvis, meanwhile, might amplify the microtrauma that occurs to the artery during the cycle of hip extension and flexion. In short, though, it's not yet clear whether one sex is more susceptible to the condition than the other. For cyclists diagnosed with external iliac artery endofibrosis, the conservative advice is often to stop riding as hard as they currently are and adopt a more upright position on the bike. For professionals who want to continue racing, though, that's not really an option, and in that case, surgery is the only real way to treat the condition in a meaningful and long-lasting way. The standard treatment these days involves opening up the section of affected artery, then adding a patch to the artery to increase its internal diameter and therefore the possible blood flow. Synthetic vein patches can be used, but more often surgeons will harvest part of the patient's own great saphenous vein, a large vein that runs the length of the leg, and use that to patch the affected artery. This is why you'll sometimes see photos of cyclists with incisions on both their leg, from the vein harvest, and their abdomen, from repairing the iliac arteries after surgery. In the words of Dr. William Campbell, it's a, quote, big surgery, end quote, taking anywhere from 90 minutes up to 3 hours and requiring access to the iliac arteries deep in the pelvis through the abdominal muscles and other tissue layers. And with a big surgery comes a lengthy recovery period. When we hear about professional cyclists recovering from endofibrosis surgery, we often hear that they won't be doing any riding at all for 6 weeks. This isn't like a collarbone fracture where pros are back on the indoor trainer within a week. When recovering from iliac artery surgery, pushing the limits can have disastrous consequences. As Dr. Campbell tells Escape, quote, there was a rider over in Europe who had a prosthetic patch. He went out too hard too early and he burst the patch and he died, end quote. And so, for their own good, athletes are told to be conservative with their recovery, to give their body a chance to recover properly. Dr. Campbell says, quote, if you say to an athlete you're allowed to do something, they're going to push it a bit harder. So I just say to them, no, you're not doing anything on the bike for 6 weeks. That means that the abdominal wall has a chance to heal soundly, and the vein, the reconstruction of the artery, has a chance to heal soundly as well. Once they hit the 6 weeks, then I say to them, now you're in a pre-season sort of thing where you've had an injury and now you're starting to build up. And so when they go out for their first rides in the first couple of weeks, they start to build it up, and they're testing themselves out. But soon enough, they're back into fairly high performance. And then they usually really notice the difference in performance. End quote. In Dr. Campbell's experience, surgery tends to have great long-term outcomes for cyclists, with many improving their performance compared to where they were pre-treatment. He says, quote, I think that almost all of them get back to better than they were before. What they've been finding is that they've been dealing with this endofibrosis for longer than they think, and they've been wondering why they're struggling a bit. And they put it down to maybe I'm out of condition or I'm out of form, other things. And then if they've got the diagnosis and they have the operation, they're free to ride as hard as their lungs and their cardiovascular system can take. End quote. Dr. Campbell's perspective seems to be supported by the medical literature. In a 2015 study looking at how high-performance athletes return from iliofemoral arterial surgery at one expert centre in France, 97% returned to sport. And in 97% of those cases, long-term athletic performances had improved 3 years post-surgery. The vast majority of the nearly 500 athletes in that study had an arterial blockage due to endofibrosis. And the vast majority of the athletes in the study were cyclists. Similarly, a 2023 paper out of the Netherlands considered the recovery of 68 endurance athletes who had surgery, including vein patching, to treat iliac artery endofibrosis. The authors found that, quote, in the short term, less than 1.5 years, 91.2% of patients reported symptom reduction, with a 93.7% overall satisfaction rate. After a median of 11.1 years, the overall satisfaction was 91.7%. 94.5% of patients reported persistent symptom reduction. End quote. Gem Arnold notes that there is still work to be done to understand how best to manage athletes' return to sport, though, saying that the time frame for returning to competition can vary quite a bit for different athletes. Some athletes have returned quickly to a world-class level, like Marianne Vos, who had surgery at the end of her 2023 season, then won Omloop Het Nieuwsblad in early 2024. Other athletes experience a slower return, sometimes reporting not feeling back to their best for nearly a full season. And unfortunately, some athletes find they can't return to their top level after surgery at all. Professional cyclists are particularly prone to external iliac artery endofibrosis in a way that most other cyclists aren't. They ride in particularly aggressive positions, they spend a hell of a lot of time riding, and their max efforts pump a lot more blood through their iliac arteries than amateur cyclists do. Or as Jem Arnold explained it to Escape, quote, "If you're not fit enough to actually drive the blood flow to even encounter that local limitation, if something else is limiting you first, like cardiovascular fitness, then you're never going to have that issue. And so it almost requires some kind of minimal fitness level for that local anatomical structure to be a limiting factor." End quote. And yet the condition can certainly occur in amateur athletes. Dr. William Campbell says he has treated plenty. He says, quote, "There are lots of amateurs, and those people that I've seen in the amateur group have had as bad pathology as professionals really, and some of them get to the point where they actually block the artery completely." End quote. But even if you're a rider who's experienced symptoms that sound like endofibrosis, numbness, cramping, pain, or a lack of power at high intensities, and even if those symptoms disappear a few minutes post-effort, looking into endofibrosis shouldn't be your first port of call. Arnold says, quote, "Step one is to see your local physiotherapist or your local clinician, and that clinician should just evaluate the athlete as they would for any other sports injury. The clinician should not and will not immediately go to suspecting a vascular cause. There's other potential causes. If the physio assesses the rider and finds that they have some biomechanical asymmetry or some musculoskeletal complaints, they should treat that and see if that starts to improve things. And this is part of this clinical diagnostic pathway. We rule out those other more common sports injuries. And then, if they're still having issues, if the athlete's not responding to the treatment as we'd expect, then we start to think, oh, okay, maybe there's something else going on." End quote. If you're concerned that you might have endofibrosis, one step you can take yourself is to check out the helpful self-check tool from Dr. Hof Schepp, a sports doctor at Maxima MC in the Netherlands. By answering some questions about your riding experience and the sort of pain you're having, the tool can tell you the likelihood that you have a vascular condition. You can find that self-check tool via a quick Google search, or via the companion article to this podcast episode. Initial treatment options, if you are ultimately diagnosed with endofibrosis, will likely depend on how seriously you ride and how seriously you want to ride in future. As noted earlier, moving to a more upright bike position is an easy first step to reduce symptoms. Working with an experienced bike fitter is recommended, but reducing reach with a shorter stem length and higher handlebars will help keep the hips open. Moving to shorter crank lengths might help as well, given it reduces how far the thigh closes off the hip angle to the torso. Athletes are also recommended to reduce the amount of high-intensity training they're doing, or stop completely, but less restrictive options can be attempted first. This includes adding more brief rests during interval training and performing high-intensity training in a more upright or even standing position to reduce how much the hip angle limits performance. Dutch researchers suggest that more than 20% of professional cyclists will suffer from external iliac artery endofibrosis, or a similar condition at some point in their career. Some have even suggested that endofibrosis should be viewed as an occupational disease for those who ride professionally. But as debilitating as the condition can be, clear progress is being made. It's not long ago that external iliac artery endofibrosis was a mysterious, hard to diagnose, and sometimes even career-threatening condition. Nowadays, the condition is being recognised more often and more quickly, which can only be a good thing. Better screening tools, growing awareness among medical professionals and those within the sport, plus proven surgical outcomes, all combine to provide riders today with a clearer path from frustrating symptoms to full recovery. As for Sarah Jagante, her recovery has gone about as well as it could have. She's now roughly 6 months post-surgery, and the debilitating pain she experienced last year is now completely gone. She tells Escape, quote, "My leg feels amazing. I don't think about the surgery or the endofibrosis anymore. The only thing it's left me with is better power, more comfort, and a huge purpley keloid scar from the height of my belly button to halfway down my inner quad. I find myself averaging 90 to 100 RPM for pretty much all my rides without thinking about it, which is something I can't remember doing for years." End quote. In her first race back after surgery, stage 1 of the Tour of Norway in late May, Jagante took 3rd place in the uphill finish. On the opening stage of the Tour de Suisse in mid-June, she was one of only 6 riders in the front group at the top of the day's main climb. The other riders all ended up in the top 5 overall. 8th on the final stage of the Tour de Suisse saw Jagante finish 12th overall. An encouraging result in her first World Tour race in 8 months, and a great sign that she's back on track to fulfill her enormous potential. In Gigante's own words, quote, "Having 2 working legs is making a surprisingly big difference."
This episode was produced, edited, and mixed by Will Jones at Red Bricks Media.